Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based clinical review of transient synovitis, one of the most common causes of acute hip pain in children and a high-yield topic for general pediatric physicians. We will work through 15 carefully designed clinical cases covering clinical presentation, physical examination findings, pathophysiology, investigations, the Coker criteria, treatment, recurrence risk, long-term associations, and age-specific differential diagnosis. Let us begin. Case 1. A 5-year-old boy presents to the emergency department with sudden onset of left hip pain that began yesterday morning. His mother reports he has been limping since the pain started and now refuses to walk or bear weight on the affected leg. She mentions he had a mild upper respiratory infection with runny nose and cough about 1 week ago, which has since resolved. The child appears comfortable when sitting but becomes distressed with any attempt to move the hip. He is afebrile with normal vital signs. Which of the following best describes the most likely clinical presentation of this condition? Option A. Systemic illness with high fever and malaise. Option B. Traumatic injury with visible bruising and swelling. Option C. Gradual onset of bilateral joint pain over weeks. Option D. Acute unilateral hip pain with limping and normal temperature. The correct answer is Option D. Acute unilateral hip pain with limping and no fever. Transient synovitis classically presents with sudden onset of unilateral hip pain causing an antalgic gait or refusal to bear weight. A key distinguishing feature is that the child is afebrile or has only a low-grade temperature and otherwise appears well and comfortable when the hip is not being moved. A preceding viral illness, most commonly an upper respiratory infection, is reported in the majority of cases, typically occurring 1 to 2 weeks before hip symptoms appear. This post-infectious pattern is a strong clue toward the diagnosis of transient synovitis rather than septic arthritis. Case 2. A 6-year-old girl presents to the emergency department with a 2-day history of right knee pain. She is limping and refuses to run or jump. Her mother reports no trauma or falls. Physical examination of the knee shows no swelling, erythema, or tenderness, and range of motion of the knee is normal and painless. However, she walks with an antalgic gait favoring the right leg. Her temperature is 37.2 degrees Celsius, and she had an upper respiratory infection 1 week ago. What is the most likely explanation for her knee pain? Option A. Patellofemoral pain syndrome. Option B. Referred pain from hip joint pathology. Option C. Juvenile idiopathic arthritis of the knee. Option D. Osgood-Schlatter disease. The correct answer is Option B. Referred pain due to hip joint inflammation. This case illustrates one of the most important clinical pearls in pediatric musculoskeletal medicine. The obturator nerve supplies both the hip joint and the medial knee, so irritation of the hip joint capsule and transient synovitis can refer pain distally to the knee. Up to 15% of children with hip pathology initially complain of knee pain, making the knee a potential red herring. The critical rule is this: always examine the hip in any child presenting with knee pain and a normal knee examination. Failure to do so is a common cause of delayed diagnosis in both transient synovitis and more serious conditions like slipped upper femoral epiphysis. Case 3. A 4-year-old boy presents to your clinic with a 2-day history of limping. His mother noticed he has been walking differently since yesterday morning. He denies significant pain but appears to favor his right leg. There is no history of trauma or fever. On examination, the child is cooperative and afebrile. You decide to assess his hip range of motion to identify any restrictions. Which specific hip movement is most commonly restricted and serves as the most sensitive physical examination finding for detecting transient synovitis? Option A. Hip flexion restriction. Option B. Hip extension limitation. Option C. Internal rotation restriction. Option D. Abduction movement limitation. The correct answer is Option C. Internal rotation restriction. Restriction of internal rotation is the most sensitive physical examination finding in transient synovitis. The child instinctively adopts a protective hip position of flexion, abduction, and external rotation to minimize intra-articular pressure from the joint effusion. The log roll test is a particularly reliable bedside technique. With the child supine and hip extended, the examiner gently rolls the leg inward. Resistance or pain with this maneuver is highly suggestive of hip pathology. Always compare both hips, as the restriction may be subtle in early cases. This asymmetry between the affected and unaffected side is often the most telling finding on examination. Case 4. A 6-year-old girl presents with right hip discomfort. During examination, you position her supine and flex her hip to 90 degrees, then abduct and externally rotate the leg while applying gentle downward pressure. She immediately reports sharp anterior hip pain and asks you to stop. Which specialized orthopedic test are you performing? Option A, Thomas test for hip flexion contracture. Option B, Trendelenburg test for hip abductor weakness. Option C, flexion, abduction, and external rotation test for intra-articular hip pathology. Option D, Ober test for iliotibial band tightness. The correct answer is option C, the flexion, abduction, and external rotation test, commonly called the Faber test. This test specifically assesses hip joint integrity. When pain is localized to the anterior hip during this maneuver, it indicates intra-articular pathology, such as transient synovitis, septic arthritis, or other causes of joint effusion. If pain is felt posteriorly in the pelvis, sacroiliac joint involvement is suspected. If radiating leg pain occurs, lumbar nerve irritation should be considered. The flexion, abduction, and external rotation test is particularly valuable when children cannot cooperate with active range of motion testing, as it allows the examiner to assess the joint passively and systematically. Case 5. A 6-year-old girl presents with acute left hip pain and limping that began 3 days ago. Her mother reports she had a mild upper respiratory tract infection with runny nose and cough about 10 days prior, which resolved completely. The child is now afebrile, alert, and playful but refuses to bear weight on the left leg. Physical examination shows limited internal rotation of the left hip. Laboratory results reveal a normal white blood cell count, mildly elevated erythrocyte sedimentation rate at 28 mm per hour, and C-reactive protein of 1.2 mg per deciliter. What is the most likely underlying pathophysiological mechanism causing her synovial inflammation? Option A, direct bacterial invasion of the synovial membrane. Option B, post-infectious immune-mediated inflammatory response. Option C, autoimmune destruction of articular cartilage. Option D, mechanical trauma causing capsular irritation. The correct answer is option B, post-infectious immune-mediated inflammation. Transient synovitis is not caused by direct bacterial invasion of the joint. Instead, it results from an immune-mediated inflammatory response triggered by a preceding viral or bacterial infection. The synovial membrane becomes inflamed and produces a sterile effusion, meaning synovial fluid cultures remain negative. This is a self-limiting inflammatory process, which is why symptoms resolve completely with supportive care alone. The mildly elevated inflammatory markers in this case are consistent with a post-infectious state, not the markedly elevated values that would be expected in septic arthritis. Understanding this mechanism helps explain why antibiotics are not indicated in true transient synovitis. Case 6. A 6-year-old girl presents with left hip pain 3 days after recovering from a viral upper respiratory infection. Physical examination reveals limited internal rotation and mild joint effusion on ultrasound. Laboratory workup shows normal complete blood count and erythrocyte sedimentation rate, but additional immune markers are ordered to investigate the pathophysiology. Which immune marker is most frequently elevated in the serum of children with transient synovitis? Option A, interleukin-6. Option B, tumor necrosis factor alpha. Option C, interferon levels. Option D, C-reactive protein. The correct answer is option C, elevated interferon levels. Research has documented elevated serum interferon in children with transient synovitis following viral infections. This cytokine plays a central role in activating the immune system and contributes to synovial inflammation through the post-infectious inflammatory pathway. Importantly, this finding supports the theory that transient synovitis is a post-infectious, immune-mediated condition rather than a direct infectious process. A key clinical insight from this mechanism is that symptoms typically appear 5 to 10 days after the initial viral illness, not during the acute infection itself. This delayed presentation is an important distinguishing clue when taking the history. Case 7. A 5-year-old boy presents to the emergency department with a 2-day history of left hip pain and limping. He had a viral upper respiratory infection 1 week ago. On examination, he holds his hip in flexion and external rotation and cries when you attempt internal rotation. Vital signs are normal with no fever. Which imaging modality is most sensitive and appropriate as the initial study to detect hip joint effusion in this child? Option A, plain radiographs of the pelvis and hip. Option B, ultrasound of the hip joint. Option C, magnetic resonance imaging of the hip without contrast. Option D, computed tomography scan of the pelvis. The correct answer is option B, ultrasound of the hip joint, which is the gold standard for detecting hip effusion in children. Ultrasound sensitivity approaches 95% for detecting hip joint effusion, making it the most sensitive and appropriate initial imaging study. It is non-invasive, provides real-time imaging, and carries no radiation exposure, which is particularly important in children. A capsular distance greater than 7 millimeters is considered significant for effusion. Additionally, ultrasound can guide diagnostic aspiration when needed to differentiate transient synovitis from septic arthritis. Plain X-rays are useful to rule out bony pathology such as fractures or slipped upper femoral epiphysis, but they are not sensitive for detecting soft tissue effusion. Magnetic resonance imaging provides more detail, but is reserved for complex or persistent cases. Case 8. A 4-year-old girl presents to the emergency department with a 2-day history of right hip pain and limping. Her temperature is 38.8 degrees Celsius. She refuses to bear weight and cries during hip movement. Her mother reports she had a runny nose last week. Initial laboratory results show a white blood cell count of 14,200 per cubic millimeter, an erythrocyte sedimentation rate of 45 millimeters per hour, and C-reactive protein of 3.8 milligrams per deciliter. Which combination of findings represents the complete Kocher criteria for predicting septic arthritis risk? Option A, fever above 38.5 degrees Celsius, inability to bear weight, white blood cell count above 12,000, erythrocyte sedimentation rate above 40. Option B, temperature above 37.5 degrees Celsius, C-reactive protein above 2, joint effusion on ultrasound. Option C, hip pain, limping, elevated inflammatory markers, and recent illness. Option D, joint aspiration findings, magnetic resonance imaging changes, and clinical presentation. The correct answer is Option A, the 4 classic Kocher criteria. The Kocher criteria are essential for predicting septic arthritis risk in a child with acute hip pain. The 4 criteria are fever above 38.5 degrees Celsius, refusal to bear weight on the affected limb, erythrocyte sedimentation rate greater than 40 millimeters per hour, and white blood cell count greater than 12,000 cells per cubic millimeter. When all 4 criteria are present, the predicted probability of septic arthritis approaches 99%. Hip aspiration is recommended when 2 or more criteria are present. In our case, this girl has 3 of the 4 criteria, which places her in a high-risk category requiring urgent evaluation. C-reactive protein above 2 milligrams per deciliter has also been added as a 5th predictor in some modified versions of these criteria. Case 9. A 5-year-old boy presents to your clinic with a 2-day history of left hip pain and limping. He had a mild upper respiratory infection 1 week ago, but is now afebrile. Physical examination reveals restricted internal rotation of the left hip with no swelling or erythema. Hip ultrasound shows a small joint effusion. Laboratory studies show normal white blood cell count and mildly elevated erythrocyte sedimentation rate. You diagnose transient synovitis. What is the most appropriate initial management approach? Option A, immediate referral to orthopedic surgery for hip aspiration. Option B, prescription antibiotics and strict bed rest for 1 week. Option C, nonsteroidal anti-inflammatory drugs, activity modification, and close follow-up. Option D, corticosteroid injection into the hip joint. The correct answer is Option C, nonsteroidal anti-inflammatory drugs, activity modification, and close follow-up. Transient synovitis is a self-limiting condition, and the cornerstone of management is supportive care. Treatment includes rest from weight-bearing activities, nonsteroidal anti-inflammatory drugs such as ibuprofen for pain control, and activity modification until full mobility returns. Antibiotics are not indicated because this is not a bacterial infection. Corticosteroid injections are not standard for this condition. Hip aspiration is reserved for cases where septic arthritis cannot be excluded based on clinical and laboratory criteria. Parents should be educated that recovery typically occurs within 10 to 16 days, and they should return immediately if the child develops high fever, worsening pain, or inability to move the hip at all, as these signs may indicate progression to or an alternative diagnosis of septic arthritis. Case 10. A 7-year-old girl diagnosed with transient synovitis has been treated with ibuprofen and activity restriction for 3 days. Her parents report significant improvement. She now walks with only a mild limp and denies hip pain during quiet play activities. Physical examination shows improved range of motion with minimal discomfort on internal rotation. When should this child be cleared to return to full impact physical activities and competitive sports? Option A, immediately, since she shows significant improvement after 3 days. Option B, after 1 full week of complete symptom resolution. Option C, when she achieves pain-free walking and full range of motion. Option D, Only after follow-up imaging confirms complete joint recovery. The correct answer is option C. Return to full activity when the child achieves pain-free ambulation and full range of motion. Premature return to impact activities significantly increases the risk of recurrence. Full restoration of range of motion indicates that the synovial inflammation has resolved and the joint has healed. Pain-free walking confirms that the joint can tolerate axial loading safely. 75% of children achieve full function within 2 weeks of onset, and early activity resumption has been shown to double recurrence rates in some studies. Imaging confirmation is not required for return to activity in straightforward cases. A follow-up visit at 1 to 2 weeks post-diagnosis is recommended to confirm full recovery and provide clearance. Case 11. A 6-year-old boy presents with his second episode of transient synovitis within 18 months. His first episode resolved completely with conservative treatment. Both parents are concerned about future episodes and long-term prognosis. His previous episode 8 months ago resolved in 10 days. The current episode has a similar presentation with hip pain and limping, no fever, normal inflammatory markers, and mild joint effusion on ultrasound. What is the documented recurrence rate for transient synovitis in pediatric patients? Option A, less than 5% of children experience recurrence. Option B, approximately 15 to 25% of children have repeat episodes. Option C, nearly 50% of patients develop recurrent episodes. Option D, recurrence occurs in over 60% of cases. The correct answer is option B. Approximately 4 to 25% of children experience recurrence. The reported recurrence rate varies across studies, but generally falls in the range of 4 to 25%. Peak recurrence occurs within 6 months of the initial episode. Children who have already experienced one recurrence are at higher risk for further episodes. The most common age group affected is 3 to 8 years old. Parents should be educated clearly about the warning signs of recurrence and the importance of returning for reassessment. A follow-up appointment within 2 to 4 weeks after each episode is recommended. Reassurance is key, as the vast majority of children recover fully without long-term joint damage. Case 12. A 6-year-old boy was diagnosed with transient synovitis of the left hip 5 weeks ago. Despite initial improvement with rest and nonsteroidal anti-inflammatory drugs, he continues to have mild hip pain and occasional limping. His parents are concerned because symptoms have persisted longer than expected. Follow-up ultrasound shows persistent small joint effusion. Physical examination reveals mild restriction in hip abduction and internal rotation. Which orthopedic condition is most commonly associated with or may follow transient synovitis in children? Option A, slipped capital femoral epiphysis. Option B, developmental dysplasia of the hip. Option C, Legg-Calvé-Perthes disease. Option D, juvenile idiopathic arthritis. The correct answer is option C, Legg-Calvé-Perthes disease. There is a recognized but debated association between transient synovitis and Legg-Calvé-Perthes disease. Studies report up to 3% incidence of Legg-Calvé-Perthes disease following transient synovitis episodes. The proposed mechanism is that prolonged joint effusion may compress the blood vessels supplying the femoral head, leading to ischemia and subsequent avascular necrosis, which is the pathological basis of Legg-Calvé-Perthes disease. The key clinical rule is that persistent hip effusion beyond 4 weeks warrants close follow-up and advanced imaging, typically magnetic resonance imaging, to rule out early avascular necrosis. This case, with persistent symptoms and effusion at 5 weeks, should prompt urgent further investigation. Case 13. A 6-year-old girl presents with right hip pain and fever. Physical examination reveals limited range of motion and refusal to bear weight. Laboratory results show a temperature of 38.8 degrees Celsius, white blood cell count of 13,200 per cubic millimeter, erythrocyte sedimentation rate of 45 millimeters per hour, and C-reactive protein of 4.2 milligrams per deciliter. Which laboratory marker is the most sensitive independent predictor of septic arthritis in this clinical scenario? Option A, elevated white blood cell count above 12,000 per cubic millimeter. Option B, erythrocyte sedimentation rate greater than 40 millimeters per hour in a febrile child. Option C, C-reactive protein level exceeding 2 milligrams per deciliter. Option D, combined elevation of both erythrocyte sedimentation rate and white blood cell count. The correct answer is option C, C-reactive protein level exceeding 2 milligrams per deciliter. C-reactive protein is the most predictive single laboratory marker for septic arthritis in the evaluation of pediatric hip pain. It rises earlier than the erythrocyte sedimentation rate in the course of infection and correlates more closely with bacterial infection severity. A C-reactive protein above 2 mg per deciliter should prompt serious consideration of hip aspiration to rule out septic arthritis. The practical clinical algorithm is hip pain with fever, then check C-reactive protein, and if it exceeds 2 mg per deciliter, consider aspiration. This marker has been incorporated into updated predictive models for septic arthritis as a fifth criterion alongside the classic 4-Coker criteria. Case 14. A 7-year-old boy presents to the emergency department with a 2-day history of bilateral hip pain and difficulty walking. His mother reports he had a mild cold last week, but has been afebrile throughout. On examination, he walks with a wide-based, waddling gait. Both hips show restricted internal rotation. Laboratory results show a normal white blood cell count of 9,800 per cubic millimeter, mildly elevated erythrocyte sedimentation rate of 22 millimeters per hour, normal C-reactive protein of 1.1 milligrams per deciliter, and temperature of 37.3 degrees Celsius. Bilateral hip ultrasound reveals joint effusions measuring 4 millimeters on the right and 6 millimeters on the left. What is the most accurate statement regarding bilateral transient synovitis? Option A. It occurs in approximately 15 to 20% of cases. Option B. It always indicates septic arthritis requiring urgent surgery. Option C. It occurs in 1 to 4% of cases and may suggest recurrent disease. Option D. It is more common than unilateral presentation. The correct answer is option C. Bilateral involvement occurs in 1 to 4% of transient synovitis cases. While uncommon, bilateral presentation requires a careful and systematic evaluation for systemic causes. The differential diagnosis must include juvenile idiopathic arthritis, systemic lupus erythematosus, viral arthritis syndromes, and reactive arthritis, all of which can present with bilateral joint involvement. In this case, the normal inflammatory markers and afebrile status are reassuring and more consistent with transient synovitis than a systemic infectious or autoimmune process. However, children with bilateral presentation have higher recurrence rates and may have an underlying predisposition that warrants closer follow-up and a lower threshold for further investigation. Case 15. A 12-year-old obese boy presents to the emergency department with a 2-day history of right hip and groin pain. The pain worsens with walking and is most severe when getting out of bed in the morning. He denies recent illness or trauma. On examination, he walks with an antalgic gait favoring his right leg. His body mass index is at the 95th percentile for age. Which factor makes transient synovitis less likely than slipped upper femoral epiphysis in this patient? Option A. Recent absence of viral illness. Option B. Age greater than 10 years. Option C. Presence of morning stiffness. Option D. Unilateral hip pain presentation. The correct answer is option C. Age greater than 10 years is the most important factor here. Transient synovitis typically affects children aged 3 to 8 years, with peak incidence at 5 to 6 years. A 12-year-old obese adolescent is well outside the typical transient synovitis age range. In contrast, slipped upper femoral epiphysis peaks in obese adolescent boys aged 12 to 15 years, making it the leading diagnosis in this presentation. Klein's line assessment on anteroposterior X-ray is essential in this age group. Normally, Klein's line drawn along the superior femoral neck should intersect the lateral portion of the femoral head. Disruption of this relationship suggests slipped upper femoral epiphysis and requires immediate orthopedic consultation. Children under 3 years of age with hip pain should raise suspicion for septic arthritis above all other diagnoses. Before we conclude, we want to tell you about the Pediatric Case Review community on Patreon. If you find these case-based lectures helpful, our Patreon community is designed to take your learning to the next level. All videos are organized by system in one place, so you can efficiently access comprehensive pediatric content without searching through individual posts. All presentations used in the videos are also available as downloadable high-quality images, so you can practice with the slides, review the cases, and study all multiple-choice questions at your own pace, anytime. You also get access to exclusive community discussions with fellow pediatric physicians. For details on how to subscribe, simply comment below this post, and we will message you directly with all the information you need. And that brings us to the end of this comprehensive case-based review of transient synovitis. We covered 15 clinical cases addressing every key aspect of this common and important pediatric condition. Let us recap the most critical points. The classic patient is a child aged 3 to 8 years with sudden unilateral hip pain, antalgic gait, and an afebrile status following a recent viral illness. Always examine the hip in a child presenting with unexplained knee pain. Internal rotation restriction is the most sensitive examination finding. Ultrasound is the gold standard for detecting hip effusion. Use the Coker criteria to stratify risk for septic arthritis, and use C-reactive protein as your most sensitive single marker. Treatment is supportive with nonsteroidal anti-inflammatory drugs and activity restriction. Follow up all cases and be alert for leg-calf-Pertus disease if symptoms persist beyond 4 weeks. If you found this lecture valuable, please subscribe to Pediatric Case Review for more evidence-based weekly lectures. Share your clinical experiences in the comments, and feel free to request future topics. We read every suggestion